Great. I'll do a roll call vote. Commissioner Chung,
Here.
Commissioner Guillermo,
Here.
and Commissioner Chow.
Here.
Commissioner Chung, would you like me to call the items? Okay.
Yes, please.
Sure. Item 2 is approval of the minutes of the June 1st, 2021 Finance and Planning Committee meeting.
Move approval.
I'll second.
Okay, all in favor? Do we have comment on the minutes?
Yeah, I just had one modification, which was more for clarity on page 2 under comments for item 5. It asks, or it says that I asked how many city employees, but of course it isn't just the employees for the city, and so I think if we remove the word city, it would be clearer, because first thing you think about is just the city and county employees, but the program, of course, is inclusive of all San Francisco employees. So we could actually say, maybe that's what we should say, ask for how many San Francisco employees.
I'm happy to replace that word.
So that's my only suggestion as a editorial modification to the minutes.
Commissioners, any other comments or?
None for me.
The folks on the public comment line, I'm not sure if you're here to make comment. If you are, this is item 2 in the minutes. Please let us know by pressing *3 if you'd like to make comment. All right, no public comment, Commissioner. So you're able to vote on the revised minutes.
Yes. With the revised minutes, do we have an approval?
I will go through the roll call vote. Commissioner Chung?
Yes.
Commissioner Chow?
Yes.
And Commissioner Guillermo?
Yes.
All right, thank you. Item 3 is the monthly contracts report.
Hi, good afternoon. Yes, afternoon, Commissioners. Michelle Ruggles, Director of the Department of Public Health Business Office. So I will just run through the monthly contracts report, and if you have questions, feel free. And we also have staff here to represent and further ask questions. And I will try to answer your questions that you sent in advance as I go along. And if and again, there's staff here if you have other questions. But so the first contract is called Addiction Research and Treatment Services. This this is an amendment to extend the term of the contract and add the corresponding funding to about $8.5 million per year. And the focus is to provide opioid treatment and substance abuse education for people with an opioid addiction. The primary service is methadone services that they provide. Commissioner Chow asked about the Art Facet program, mentioning that they have 18 clients and what is the cost for that program. And the program does have 18 clients, and the cost annually is $237,544. We're licensed, or they're licensed to go up to 50 clients, but this is the capacity that we currently contract with them for. And by the way, you would have just received this, but we did you have a document, I think, in an email that has answers to these questions. So if you have more questions, I'm happy to refer you or see if I can answer them, but we also have staff here.
Commissioners, any questions?
I guess my question is at $237,000 per client on the FACET program, is that what we're really believing that we should be paying for this? I mean, that just seems perhaps high. And if they were 50 patients and was half the cost, I can understand that. But the way that it seems to be parsed out, I'm wondering if that is the most efficient use of dollars. I mean, it's a very important population, but looks to me like we're expending a lot of money, and do they then have something to show that with the $237,000 that we actually are having good results from it? And could they not use or could it not be more effectively on a financial basis? I mean, it just seems like an awful lot of money for a very, very important group, but
I will defer that question to, is Eric Dubon on there, Mark?
Yes, he is here.
Yes, Michelle, I'm here. Good afternoon, Commissioners. Commissioner Chow, you are correct. This is some of the same concerns that we had with this program. That is very high cost, but on the other hand, it's a population that we need to serve, and it's also very small population in the city because we don't have a lot of pregnant women or children that we can serve. But we are trying to expand the program and also to provide other services like buprenorphine or telehealth services, so to make it more competitive, the cost. But yeah, we are working with the program. And also some of these services are drug medical, so they are under the organized delivery system, so which is the drug medical services, and we are billing for some of these services to DMC.
okay, I guess you're also looking at the same too. Do we know if we had 18 people last year, did the 18 people actually have a good outcome?
Yes, we do have outcomes. So we had the Business Office of Contract Compliance do annual monitorings. So, and they are always outstanding or exceed the expectations based on our monitoring report. Yes, we do have good outcomes with the services.
So is the outcome that both the mother and infant, and particularly the infant, then is in good health?
Yes, yeah. And also we were able to place some of them on the residential treatment facilities, such as Health Right 360, which is the women's hub. And also we have other residential step-down programs, Epiphany, which they serve mother with children. And also in the Bayview, we have Jelani Family Program, which they serve also women and children.
Okay, I guess you're aware of the problem, and it is a population that's needed. It just seems that we should be at a lower cost for all of this, but I defer to my fellow commissioners.
Yeah, I think that this is where, like we really want to like have some discussions around what exactly we constitute good health outcomes for a program like this when it's so high cost. So would it be just the outcome is what are the indicators that you use, to measure those outcomes?
So some of the indicators are how long they stay in the program, if they successfully meet the objectives. Like we have in the residential programs, they have to participate in individual counseling or group counseling. So according to the DMC and the ASAM guidelines, they have to attend at least 2 outpatient program services a week, 2 sessions, and also one of the group counseling. Due to COVID-19, some of these programs were able to engage clients through telehealth. So they provide services via WebEx or Teams or Zoom. And on the residential programs, they were able to do one-on-one counseling, always maintaining social distancing.
Okay, thank you. I think that it's that's the part that we really needs to like get some kind of like minutes, like documenting that we can't really control the cost from our end, as commissioners, but we can definitely, have some clarifications on, how do you measure the successes of it. So thank you for like sharing that information.
So yeah, and also we report annually, quarterly to the DHCS, the perinatal division. We report quarterly what are the activities for these perinatal programs, and FACET is one of the programs that we have to report quarterly to the DHCS.
Thank you. And I believe, like this is a much needed service. It's not like there are a lot of other competing programs out there. So
There is, yeah,
yeah,
correct. There are
so
few programs.
yeah, so I think that's also one of the reasons why, like they decide that they can, like ask for higher fees for service.
Yes, that's yeah, correct.
That's
Thank
that's the market.
yes.
So, Commissioner Chan, do we understand that the first answer was that the children that were born were fine? And is that correct, that all 18 had delivered and that the child was, I don't care whether the child was placed or whatnot, but from a medical standpoint, was the birth uneventful? And it seems to me that the goal is to have a child free of drugs.
Yes, correct. So yeah, that's part of one of the objectives from the standpoint of health, and we work also closely with the jail system, because some of them are coming from the jail system, and also with San Francisco General, the I think it's Ward 95, that we work closely with women and children to ensure that they born drug free.
So Mark, remind me, I don't think that, like we've ever invited um, this program to come present at the Populations and Health, correct? I think that might be a place that we should have a continue conversations about the programs, because like one thing is, like the goal of the program is for the women to deliver healthy babies, but also, I'm curious, so you don't have to answer this moment, is like what are some of the other continuity of care we provide for the mother, like after, like they deliver a healthy baby. So and I think that, like for us, like some kind of ways to understand how we measure long-term successes for a program like this is just as important. But yeah, but Mark, if we can like consult with Commissioner Gerardo and see if we can like schedule this for a presentation.
Just very quickly, Commissioner Christian asked for a similar presentation, but from a postpartum depression side. So maybe there can be a whole pregnant person services and follow-up and included this program. So I'll note that. Thank you.
Great, thank you.
I have a question, being new to this committee, just trying to understand sort of the scope of our responsibility and authority in approving contracts, particularly for programs that are, I guess in this case, being extended. Does this committee then approve the contracts? Just it's sort of related to the questions that are being asked on the sort of on the matter of the budget and the financing of it, or as the question as per the questions that have been asked prior to this, do we then also consider the effectiveness and the outcomes of the program before we vote on the actual extension, increase in budget, change in the budget, and so on? It seems to me there's a little bit of a disconnect then that seems to be surfacing, or maybe that's just the jurisdiction of the different committees. But as commissioners, I think we have an interest in the whole, and how do we then best execute on our responsibilities if we don't have all that information?
I think that's a really good question, Commissioner Guillermo. And here are the things that I understand, like that we are kind of at a bind is, like we do like task with approving contract, but it's not for us to decide how to shop for contract, for instance. So this, like this is already, like a decision that's made, a contract is being entered, and this is like how much the cost of the contract is. So, but what we can do, as civilian oversight commissions, we could ask for more transparencies into like what they had considered to go into the contract, and so that we could be like we can be accountable to our constituents, which is, the entire San Francisco, that this is how the money is spent. And, that we will be able to like see a broader picture than just a contract that we put a rubber stamp on.
So
And
just to go a little bit further with that, then if there was say in this case, questions about the efficacy of the program, and we were looking for additional data before approving the contract, would not approving the contract until we get that data, what impact would that have on the program? Yeah.
We actually have done that in the past, like delaying a certain contract, like to get more information. It wouldn't really, like in practice, it wouldn't like affect, like the business operation side of things. But but on record, like we're just delaying our process because we'd like to have more information. Is that right, Mark?
Yes, commissioners, if I can jump in, and then I know Ms. Ruggles may have a response too. In my tenure here, what's been done and what's sometimes been effective is if you have issues and you really aren't comfortable passing the contract or modification for whatever reason, you can first ask and say, if we delayed this, what impact would this have? Sometimes there's services that won't be paid for or something won't start, which is really important. Other times it's no problem at all administratively to delay that approval. And so an important question is always to ask, what impact will our delay, if we delay, have, number one. And then you can ask for whatever you need. And Michelle Ruggles is fantastic with letting you all know the lay of the land around how this will impact the future services. But I personally don't want you to feel like you need to move forward with anything, Commissioner Guillermo, that you're not comfortable with. So even though you're new, I want you to feel like you can ask for information and move forward. Usually, as Commissioner Chung said, you all don't have purview over the cost of something. You can just say, like, how did you all come to this? Did you check best practices? Are there comparison? Is this out of nowhere? And you can get at, as Commissioner Chung said, transparency on the decision making. But usually you all don't get in the weeds of, well, I think this should be $5 cheaper. Come back and make it $5 cheaper. That's not your purview. It's more about asking questions about process and how you came to it, asking for data, and then deciding to either approve it or not approve it. I hope that's helpful.
Yeah, that was very helpful. Thank you.
And trust me, sometimes I'm pretty sure that we do feel like what we'd like to see, the cost to reduce.
well,
But
we
hey,
have brought it up before when there has been several contracts and the costs were variable. And we always were able to get a good explanation as to why certainly the contractors had another $10 or $20 per service versus others when they're compared. And we have that in here. But I think for Commissioner Guillermo, when we only had the Finance Committee looking at contracts, and it used to take hours, it did include a review of the quality of the programs. Since we separated out to a separate committee for looking at essentially at a broader picture of the total program, such as is being proposed here, looking basically at how the effective a program is and how we care for the entire mother and child, then we have asked that the our other committee take that up so that it, but in say a decade ago when we didn't have the other committee structured as it was, then that would also be part of the purview. So that's also why it looks like there's been a split. We can raise a question as to how the program is, and then often we will then ask our other committee to really review the entire program. So that part is sort of up to the commission how they would like to handle it, but we have always wanted to be sure that there was a component of quality that was being addressed.
Okay, thank you. Maybe it might be helpful that for those contracts that are coming up for consideration for this committee, if there had been a previous report about the outcomes or efficacy, effectiveness of the program prior, in a prior period, that might be an attachment, so that we have some of that information to go along with the consideration of the actual contract.
That's a really great idea. I think that those are also conversations that both committees, the population health and also the finance committees have been having these ongoing conversations, to try to make the best sense out of like how we do our job. So yeah, so I think that that's a great suggestion, and I do think that like for us, like we're more interested in the success stories rather than like how the day in and day out and how many like test tubes we paid for.
Exactly, yeah.
So thank you for all this. I'll talk to Ms. Ruggles about all of your requests, Commissioner Guillermo. But in terms of this contract, any other questions? Okay. So Michelle, I think we can move on to the next one.
Okay, the next contract is NetSmart Technologies, Inc. This contract requested is a renewal maintenance of our services with NetSmart to support the department's Avatar software platform. And the current maintenance contract ends June 30th, 2021. So this will extend it by 3 years. Avatar is the billing system or part of the health billing system for behavioral health services. And I know we have staff online here. And also Commissioner Chow had asked a question, which I don't know the answer to, and they can answer, is when we expect Avatar to convert to Epic. So I think Kimberly Volker and Pablo Munoz are online. Kimberly, you're on mute. And Pablo.
Oh, there you go. Oh, hi. Good afternoon, Commissioners. My name is Kimberly Volker, and I oversee the Avatar electronic health record system for behavioral health. And yes, the question did come up regarding when we were planning to move to Epic. And the plan is to move behavioral health services to Epic by the end of 2023, pending further clarification from CalAIM on requirements. And also there'll be a 6-month overlap with both applications, Avatar and Epic, to ensure that behavioral health claims are fully processed.
Any other questions, commissioners?
Well, that does answer my question, but Commissioner Guillermo has reminded me that we did ask for it has nothing to do with the Avatar. I strongly endorse Avatar's continuation because that certainly is an important a database that before we had it was even much more lacking. But I did want to remind Mark that we did ask for the reports on the continuing contractors, and with the holidays, I didn't actually want to stress that again because you only had 1 day to respond. But it would be good if it kind of became more routine.
And Commissioner Chow, you're speaking about the monitoring report outcomes.
Correct. Because
Right.
that's where I think we look at the quality, we look at the patient acceptance and so forth. It's been a very good report being given to us in the last several months, I think, when we were asking for it, because then we could get that part of the equation also.
Sure. No, I know. I think with the holiday, it changed our workflow, but thank you.
Yeah, and that's why I didn't ask
Yeah.
this time.
Any other questions, commissioners? Okay, Michelle, we can move on to the next contract. Thank you, Kimberly.
Okay, the
Yeah.
third contract is, you guys gone, is Haluna Health for the National HIV Behavioral Health Surveillance activities. And the requested action is the approval of a retroactive contract amendment with Haluna Health to increase the total contract amount with contingency by an amount of $2.2 million for the period of January 1, 2016 through December 31st, 2023. So the contract provides fiscal administration, which is used to support the Center for Public Health Research, National HIV Behavioral Surveillance activities. And so we received additional federal CDC grant funding and then carry forward funding from 2020. Of the amount, the annual funding amount, Haluna Health receives a 12.8% administrative fee. So they receive $106,000, and then the balance of $726,990 goes towards the programmatic costs. Let's see. I'm sorry, I was looking for I thought I wrote this too, the reason why this is retroactive. I don't have that reason written, but anyway, it's, so that's what this contract is. It's a request to continue the contract, and we have, I believe we have staff on hand if you have specific questions about the program.
Any questions, commissioners?
Oh, I did want to just thank Ms. Ruggles for putting in the actual administrative costs, because for Commissioner Guillermo, we do have a number of contractors like this, and it's always, I think, of interest to know what is the actual or the indirect cost that's being charged to us, because they also are, as it shows here, administering a huge amount of money that's not theirs. So I'm pleased that the department remembers to put that in so that we don't have to ask for it. Thank you.
Okay, Michelle, I believe we can go to the last contract.
Okay. This contract is with UC, the Regents of the University of California for Tertiary Care. So this is a new original agreement and coming off of an RFP, I believe. The proposed contract is authorized under RFP 5/2020. So while this is a new contract, these are ongoing services, and they were re-awarded to UCSF for these tertiary care services. And that includes of the services, cardiac care, and other highly specialized services that are not available at Zuckerberg San Francisco General. And also for this, sorry, if you have questions or staff here to answer.
Sorry, I'm just a little bit behind the times here. Is going back to the previous contract, is it possible then if you could send us a note subsequent to this meeting as to why the retroactive contract is being requested for Haluna Health?
Yeah, you know what? I found it and it wasn't really that helpful. It's the last sentence of the first paragraph under purpose. It is just simply due to timing. The subject request for approval is retroactive due to the competing contracts office requirements during the past year that resulted in this contract not being brought earlier. It's not our practice. It happens from time to time when a contract does not get brought here until it's retroactive. Just there simply was not enough staff and time during the past year to adhere to all of our common ongoing procedures.
And that's retroactive back to 12/31/20, not January 1, 2016, right?
Correct. Yeah. The first
So
one
that's
was
understandable.
already
Yeah,
okay.
got it. Okay. Thank you.
Uh-huh.
I also want to interject that, but that's actually a very good questions that Commissioner Guillermo asked. And, and those are the things that, like we definitely have, like that it's within our purview, like if we think that we want, additional like notes or memo to explain, like why the retroactive, if at all, we don't find that here. So.
Actually, that's why I was confused. We specifically include that because you asked. I just couldn't find it. And then I thought I was losing my mind, but there it was.
Is there this of course is really a important and very generous contract on the part of UCSF in covering our needs at SF General, and especially since the amount being proposed is not really increased. But does anybody know, and maybe you can give it to us later, how much in a year we actually do spend?
Hi, Commissioners. My name is Kathleen Abanilla-Huynh. I'm with the Office of Managed Care. I can tell you in 2021, we are still waiting for claims to come in, but so far we have spent about $1 million. And in 1920, we also may have a few claims still coming in, but our records show that we have spent about $1 million for that year as well.
Very, very good. Okay, no, thank you. That was just a point of curiosity. For years, the agreement has been really held to its costs. I think for several years now. So, in terms of allocation and Commissioner Guillermo, just to fill in, when we can't do something at General, for example, coronary surgery and whatnot, on patients that belong to our health plans or are indigent patients of the city, then this fund helps pay for it to UCSF. Is that a accurate, well, at least an approximate accurate statement?
I can clarify a little bit. This specific contract is to cover those who are technically uninsured. So it would be Healthy San Francisco participants or participants under the County Medical Assistance Program, as well as any inmates who do not qualify for Medi-Cal.
Oh, thank you. I appreciate your clarification.
And to add, Commissioner Chow, this is outside of the affiliation agreement.
Yes, I realize that. Yeah.
The DPH has contracts with UC, and of course, the affiliation agreement covers their basic costs. Any other questions?
So this is sits on top of that affiliation contract.
Well, it's totally separate. So there's a handful of contracts with UC, and then the affiliation pays for like the core services.
Those core services are the services at General, if I'm not mistaken.
Yes.
Affiliation agreement.
Yes.
So this is how some patients get transferred over, such as the indigent, as was pointed out, and therefore then we will pay for that because somebody has to pay for them.
So commissioners, unless you have other questions, now would be the time to consider an approval of the contract, or if you are uncomfortable with any contract, you can pull it out, any of those things, but this is now action time or consideration of action time on this item.
I move approval.
I second.
Okay, do we have public comment on the entire report?
Folks on the line, please press *3 if you'd like to make a comment on the contracts report. No comment?
Okay, and all in favor, please say aye.
I actually need to do a hand count.
Oh, yes.
A roll call. Commissioner Chun.
Yes.
Commissioner Guillermo.
Yes.
And Commissioner Chow.
Yes.
All right, thank you. The contracts report passes. We can move on to item 4, which is a request for approval of a new emergency contract with Deloitte. I never know how to pronounce this. Is it Deloitte Consulting? Is Drew? Yes, Drew, you can present.
Hi, Commissioners. Thank you. Yeah, before you is an emergency contract with Deloitte to assist us in our year-end inventory count and valuation practices and serve as confirmation. We're really doing this work in conjunction with the controller's office, and the work will directly aid our kind of financial year-end planning to accommodate some of the changes in supply method and procurement that we had to undergo during the COVID response.
Any questions, commissioners?
Actually, I had one. So this is assistance in I guess the documentation and accounting for COVID funding in order to justify the amounts that we have received, or to make sure that they're all accounted for in the right and appropriate manner.
Correct. I would say it's not so much the justification as verification and support in what we record in as of June 30th in our financial ledger, and making sure that our asset count and valuation methods are proper and according to GAAP standards. And so this is really something we're doing in partnership with the Controller's Accounting and Operations Office.
Okay, thank you.
I think I did have a question, which is mostly semantics. When we write that Deloitte has a board of 21 members, and we say that it now has 13, and there are no vacancies on the board, are we making a determination that the company has said they're only going to 113? I mean, that's up to them if they can have 21. Or is it just that that was a phrase that was inadvertently put in there?
I think that phrase was inadvertently put in there, and the correct interpretation is, I think, was provided late today, which is that Deloitte is at all times choosing the right number of board members, and they're not necessarily limited to the 13 that are listed. And I have Beth Portman from Deloitte is here to correct me and speak more appropriately to their board strategy.
Hello, everyone. You're correct, Drew. It's that the number of directors, number of people on the board of directors can be flexed to meet changing business needs. We are a large U.S. and actually global organization, so the number of representatives may vary from time to time, or there may be under special circumstances under which they'll have add additional members to the board to address some very specific circumstances, so they will adjust as business needs warrant.
That's very acceptable. Thank you.
Thank you, Ms. Portman. Any other questions, commissioners? Folks on the line, anyone have a comment on item 4? You can press *3 to raise your hand. No questions, commissioners, from the public.
And do we have a motion to approve?
So moved.
Second.
I'll do a roll call vote. Commissioner Guillermo,
Yes.
Commissioner Chow,
Yes.
and Commissioner Chow.
Yes.
The item passes. Thank you. Item 5 is a request for a retroactive approval of a new contract with HealthRight 360. And I believe Dr. Hammer is here.
Good afternoon, commissioners. Kelly Hammer, Director of Ambulatory Care for the Health Network. And this contract is for HealthRight 360, which has Lyon Martin Health Services as one of its partner clinics, and has been overseeing Lyon Martin Health Services. This was a Board of Supervisors add back last year, and we've been working with HealthRight 360 and leaders from Lyon Martin to develop the contracted activities and services, which sort of align with the vision of the supervisors in allocating this add back last year. It's a 2-year add back, and it's really meant to support HealthRight 360 and Lyon Martin to go through the organizational changes and administrative work required for Lyon Martin to again be a standalone FQHC health center and not be under the umbrella of HealthRight 360. So happy to answer any questions or give you more detail if you're interested.
Any questions, commissioners?
The only one I have right now is, do you remember when HealthRight 360 kind of merged with Lyon Martin?
Commissioner Chung, it's funny, that question occurred to me, like, how many years has this been? And I thought I meant to find out the exact date. I want to say it's been about 6 or 7 years, but I will get that exact date to you and let you know. They've continued to function, seeing patients. They have integrated behavioral health. They provide primary care services, but it has been I think both Lyon Martin and HealthRight 360 agree that the model where they're under the HealthRight umbrella is not ideal, and so the people in the community who've been advocating for HealthRight for Lyon Martin and others have really support this move for them to come out from under HealthRight. It was and also HealthRight really saw it as because of space issues and business model, not a sustainable model for them to keep Lyon Martin as part of their constellation of clinics.
Yeah, well,
I'll get you the year.
yeah, thank you, because I think that's also a larger conversations that we had before about, like, when would, like, one of these like contractors becomes like too big to fail kind of scenarios, and and like for these smaller ones, like, what can we do to support them, like, so that they don't have to like go into these kind of predicament, in the long run, like being taken over by a larger organizations. So because there's a value in community-based services still. So I think that would be a continued conversations that we're going to have, and yeah, please, if you can, Dr. Hamad, send us the year that they came together.
Yeah, I can probably even get that for you during this meeting, Commissioner Chung. And I agree. This is something worth discussing on sort of a broader, in terms of not specifically about this relationship between HealthRight and Lyon Martin, but really the bigger question, because it is hard to develop as an FQHC a sustainable business model, given the constraints for FQHCs if they're not part of a bigger system.
Yeah, exactly.
They merged in 2014.
Thanks,
Okay.
Michelle. All right, 7 years.
Thank you. Thank you. I guess this is a 7 years each.
Yeah.
I'm wondering, we know FQHCs are a challenge in terms of administration and everything, and for years before the merger, Lyon Martin, while a very valuable service, was always financially very marginal. How is this going to make it any different? Is it just going back 7 years, or are we thinking of a different scheme in which they will be successful?
That's a really good question, Commissioner Chow. They are working actually with our FQHC consultant to not just go through the administrative steps to becoming 501c3 in their own right and getting FQHC designation again, but really to develop a sustainable business plan. And, I share your concerns, like why is this not just deja vu all over again? At the same time, I will say that we're fortunate in California. One of the big things that's changed is more opportunities for reimbursement for the sort of non-specialty mental health services that they provide integrated into the primary care at Lyon Martin. So there's opportunities for generating revenue for those previously unreimbursable services. Also, with the real focus in the city on people experiencing homelessness, people with coexisting serious mental health issues, substance use issues, and the fact that they have a historical record of providing services for trans people experiencing homelessness, which is one of the priority populations for use of the city's Prop C funds. I do think that there are more opportunities now for both state providing, Medi-Cal reimbursable services, as well as working with us, the DPH, and others in the city to align their clinical services with what the city is going to support with Prop C funds and other programs associated with Mental Health San Francisco and other emerging initiatives.
Well, thank you very much.
I would imagine that if Lyon Martin, if the plan is for them to be able to return back to an independent status by 2022, that at some point separate contracts from the city to Lyon Martin are going to resume, or at least be competed for by Lyon Martin. And so it would appear to me that given the population that they're serving, that it is probably one of the most expensive populations to serve. And so planning for that eventuality is something that, separate and apart from a strategy around supporting community health centers, in the city and the region, that the type of population this particular clinic serves and the kinds of services that they provide, again, are at a price point that are not necessarily going to be accommodated even with the state's new reimbursement, opportunities and such that. So I think planning with them somehow taking all of that into account would be to their best interest, as well as to the interest of the populations that we're most concerned about as the health department and as the health commission. And I was just thinking about Commissioner Dr. Chow's question about including the administrative costs in our contracts. A 12% administrative overhead for a contract for that type of service is probably going to be woefully insufficient for what they're going to need to be able to sustain themselves. So, those kinds of considerations really are things that I hope the department is looking at and planning for, and that we might as a commission also be helpful in supporting.
Yeah, I think that this is also a value questions that as a commission need to have, discussions on, because it is directly tied to like equity, like health equity, and how much are we willing to invest in health equity and health outcomes on, some of these historically super underserved communities. So yeah, so I think that I look forward to us like having these conversations, and in our ongoing planning effort.
Yeah, I agree, commissioners. I also think I'm always a glass half full person, and I'm actually hopeful that this go round, so going back to that, like how are things different now than 7 years ago? I'm hopeful that this time with Lyon Martin again being a standalone FQHC, that we will get off on the right foot in terms of teaming up between Lion Martin and other clinical services that we provide based that are DPH services like Gender Health SF, like Dimensions Clinic. Like, I think we have a lot of opportunities for synergy and complementary services that we didn't really take advantage of in the past.
Thank you. So do we have any other questions or public comment on this?
Folks on the line, please press *3 if you'd like to raise your hand to make comment on item 5. No hands, Commissioner.
Okay, so do we have a motion to approve this contract?
So moved.
Second,
I'll do a roll call vote. Commissioner Chow,
Yes.
Commissioner Guillermo,
yes.
and Commissioner Chung.
Yes.
All right, the item passes. Thank you, Dr. Hammer.
Thank you, commissioners.
Item 6 is a request for approval of a new contract with Maxim Healthcare Staffing Services. Ms. D'Antoni.
Hello, Commissioners. This is Terry D'Antoni calling about our 3 contracts. There's a series of 3 contracts that you're going to see: Maxim, Trifecta, and Triage. All 3 of those are being looked after if we have an increase in COVID cases. We needed to get an emergency contract going so that we would have the resources if need be. Any questions?
And so, Commissioner, since Ms. D'Antoni is presenting all 3 of these together, and folks on the line and for the public in the future, we're talking about items 6, 7, and 8 on the agenda. So, Commissioners, it's okay to ask questions for any of those contracts for 6, 7, and 8.
Thank you, Mark. Sorry for jumping ahead.
I would just comment that I know that this is, at this point in time, probably the bane of any healthcare provider, to make sure that staffing is an adequate consideration, not just in terms of COVID, but now with anything, just because of the effects of the pandemic on staffing levels and on the well-being of particularly clinical staff heading into the future. So I don't doubt that these are necessary contracts to have in hand.
Thank you for that acknowledgement. It has been very difficult. And what we've learned with the other registries that we've used is that they worked the first part of the year, and a lot of them made tremendous amount of money. And currently now it's very difficult for us to find any sort of registry help. And our staff do need time off and mental health breaks as well. So thank you for that acknowledgement.
On Maxim, could you clarify that we're talking about them being based in Maryland? And
Yes.
Right.
A lot of our contractors have a headquarters somewhere, and then they have outlets in the, they have their niches in the different cities throughout the United States.
So I assume that with the RFP that you let out, and these are the 3 that were here, that they are going to be readily, well, I don't know readily because of what you were just saying.
Yeah.
So what are the total number of registries then that we could draw on at this time? Because we approved some earlier this year.
That's a very good question. Currently, we have different contractors that we're using, and we're not using COVID rates now. Our COVID census as of today, we have 3, 1 in the ICU and 2 on the floor. So we don't have any travelers that are here for COVID. And our COVID rates that we were paying ended in April and May. So right now we do have registry, and they're backfilling for retirements, for leave of absences. We've experienced at Zuckerberg, and I've spoken to my colleagues over at Laguna Honda and other places, very high amount of sick leave. We have 90 people at Zuckerberg out on leave at now nursing. So we rely on our registries to help us with that as well. And our vacancies are few, but we are going to fill all of those as well, and that will be helpful.
So these are specifically for COVID patients?
They're for COVID, and if we do need a surge and our other registries can't provide, we do have the ability on this contract to get non-COVID.
Oh, okay. Thank you.
You're welcome.
So I have a question now. Do we like make a motion for the contract individually anyways?
Yes, just for procedurally, I don't want to have any questions in the future. If we could do item by item and just go through and you all vote, I know it's a little extra time, but that way no one can ever challenge the legitimacy of the process.
Thank you, Mark. So do we, on the first contract then, Maxim Healthcare Staffing Services, do we have a motion to approve?
So moved.
Second,
Roll call vote, Commissioner Guillermo,
yes.
Commissioner Chow,
Yes.
and Commissioner Chow.
Yes. And then on the second contract, Triage LLC, do we have a motion to approve this contract?
I'll move.
So, a second.
I'll do a roll call vote, Commissioner Guillermo,
Yes.
Commissioner Chow,
Yes.
Commissioner Chow.
Yes.
Right.
And last but not least, Trifactor Incorporated. Do we have a motion to approve this contract?
I'll move.
Second.
Commissioner Chow,
Yes.
Commissioner Guillermo,
Yes.
Commissioner Chow.
Yes.
All right, thank you, Ms. Zantoni. All three contracts pass.
Thank you very much. Have a great day.
Thank you. And all the contracts plus the contract report will be added to the consent calendar for the 4:00 commission meeting for adoption.
And I should take what I just said back. It's not that they were all disapproved. They were all recommended for approval by the full commission. Thank you, Commissioner. Item 9 is the DPH third quarter fiscal year 2021 revenue and expenditure report. Ms. Louie.
Can you hear me? I managed to share, but now I can't seem to get myself
Yes,
off.
we can hear you, Ms. Louie, but we can't. It's okay if we don't see.
I can't get myself off video. I apologize, but I do have a PowerPoint to share, which I think will be the focus of the presentation and not my face. So afternoon, Commissioners. Jenny Louie, Chief Financial Officer. I'm pleased to present our third quarter financials for this current fiscal year. As in other financial reports, these reports are preliminary. They're based on our 9 months of actuals. The one thing I will note for the commissioners this year is that changes, as of course, are always possible over the course of the fiscal year, but particularly with this year with respect to COVID cost reporting, as we work with the controller and we also identify funding opportunities, we may be adjusting appropriate budget and expenditures and reallocating them to meet cost reporting guidelines as well as meeting some grant requirements. So it's possible that the numbers may wiggle around even more than usual as we're getting an unprecedented amount of support related to COVID. We're working with the Controller's Office citywide on this as they look through grants, so including the CARES Relief Fund for both providers and for counties. The projected balance that we show here is assumed to be as part of the to help offset the adopted budget for this year. And then, as in the prior quarters, the budget and projections of the new COVID project that was managed centrally by COVID Command are not reflected in our DPH operating financials, but we do show them at the end separately for the commissioner's information, but they do not affect DPH's operations and operating financial position. The third quarter summary, we essentially are in a similar, slightly improved place than we were before. Overall, we have a $13 million improvement compared to the second quarter, and this is really primarily to favorable one-time revenues, as you see here. So overall, we're projecting a revenue surplus of $22.5 million. Our expenditures are essentially expected to be on budget at this time. And then just as a reminder, in the second quarter, we did release deferred revenues of $51.7 million. So overall, $74.4 million projected fund balance as of our third quarter financial. And as commissioners may recall, the third quarter report, we continue to report the costs of our existing operating staff that are activated for the COVID response. And their their costs are reflected under the Public Health Administration Division. And again, what this does is you'll see is it shows a sort of very negative impact on the Public Health Administration Division, but positive savings elsewhere. The reason for this is that we're working with the controller to basically, one, we want to track the level of the operating support that we have to serve as a potential match for reimbursements. The reassignments that we're seeing were fairly consistent with the assumptions we had for the 2021 budget. And this also allows for more accurate cost reporting for existing divisions where we may or may not want to show one-time COVID costs. The cost allocation, again, is subject to change pending FEMA and CARES reporting, as well as additional state and federal grants that we have. And so what you'll see specifically within our financials, again, is a very large negative variance within the Public Health Administration Division. This is relatively the same for what we've seen in the second quarter, where we're at around 66 million. And then you'll see these positive variances across all of the other divisions as we reassign the costs, specifically that are tagged towards COVID efforts within our existing operations. Overall, we are expected to be 3.5 million over on salary this year, but we do expect that this overage will be offset with savings in other expenditure categories. And again, this is probably one of the trickiest areas we've had because there are so many personnel and there's so many changes to activations and deactivations. We are working with the controller on a year-end reconciliation, making sure we have appropriate documentation and justification of the staffing costs. And so at year end, these allocations may change. Going specifically into division within the Public Health Administration Division, basically we're seeing some minor positive revenues consistent with the second quarter where we have the Medi-Cal administrative activities as well as some one-time prior year settlements. And again, the significant negative salary and benefits, that's really offset by savings in other divisions. Within Zuckerberg, overall, the revenue picture is positive. Their net patient revenues is 31.6 million. One of the things that you'll notice if you actually look into the details of it is that there's some variances across the payer categories. And I think it's primarily due to variances we had from how the base budget was developed using our legacy system pre-Epic, which had a different distribution by payer category. And we're going to be adjusting the revenue budget for 21-22 to be more accurate in terms of what our expected payer categories are. But overall, the net patient revenues are positive. We do have a negative revenue of 20.9 million. This is due to a delay, not a loss, but a delay of the quality incentive program that moved into Prime, and it's sort of shifted in its timing for payments. And so I think the whole program is just shifted over about 6 months. This is a payment delay there. With the expenditure side, there's significant costs over at Zuckerberg that were allocated or tagged as COVID related. And then we have non-personnel expenditure for contracts and materials and supplies, which are over budget, as well as 2.5 million of savings within interdepartmental workers and debt service. And as I mentioned earlier, outside of our regular operating budget, we do have that 51.7 variance that we noted as part of the second quarter financials. For Laguna Honda, their patient revenues are positive by 8.9 million. This is primarily due to an increase in the federal matching, the FMAP percentage that we received. And so we received a temporary increase in our match as part of the federal government support of hospitals. And this is the positive revenue that we see here. Again, the salary and benefits are costs reassigned to the Public Health Administration divisions. And we see a slight increase in materials and supplies, a slight savings in materials and supplies. And we believe that this is primarily due to a slightly lower census as we sort of delayed admissions at one point into Laguna, but I think we're well on our way to continuing a more regular pace of readmissions and maintaining a higher level of census at Laguna. Within primary care, there's about 7 million that's being allocated towards COVID costs, and then some minor variances within contracts and work orders. Within behavioral health, we are projecting an 11.5 surplus within our short Doyle Medi-Cal revenue. As commissioners may remember, in the current year, as we were developing the budget, due to some of the uncertainty around COVID, the impact of COVID and what it would have on our operations, we did assume that we would have a reduced level of support and a reduced level of clinical operations, and so we also reduced the revenue associated with it. We're pleased to say that the impact wasn't as significant as we thought, and so our revenues are sort of higher than our expected budget, but it's sort of a little bit more aligned with what we would have seen regularly within our regular operations. And this again will also be our budget for next year does assume sort of that continued bounce back from COVID, and so we won't be seeing this surplus in the future. We'd also have one-time release of reserves due to some accelerated reconciliations by the state of 30.5 million. On the expenditure side, similar story with the salaries and benefits being reassigned to the Public Health Administration Division. We have about 10 million of contracts savings that were projected, and I think it's part related to some of the reconciliations of the prior year, so that we're able to release the reserves and perhaps release any of the existing purchase orders we may have in the prior year for contract savings there, and minor surplus within materials and supplies. Within jail health, again, minor salary and benefits and savings. We also do see a significant one-time savings in materials and supplies. And again, we do believe that this is really related to census at the jails where, particularly during COVID, when there were no vaccinations, there was a big effort by the mayor's office and the sheriff's office to reduce the census over at the jails. And this is what we're seeing here. But if you also look at our budget overall, we are essentially on budget for materials and supplies. And so, jail health is one place where people can sort of access services, but it's possible that we're also seeing them somewhere else as a whole. We will be watching this, but we do expect that should census increase at the jails, that the spending would also increase correspondingly. There are no significant variances within Health at Home. Within Health Network, we're seeing the same revenue shortfalls that we were seeing primarily around the Healthy San Francisco program with reduced patient and employer fees. This is consistent with what we've seen since the ACA. And then we are also seeing the shortfall that we've seen for the last several years related to the city option disbursements as we work with the city attorney. This is something that we're working closely with the city attorney on resolving, hopefully this summer. And so hopefully we will correct the budget for next year for these shortfalls here. But at this point, we are not recommending, we are not recognizing any of the disbursements as recommended by the city attorney. The salary and fringe benefits you see here, again, the reassignment of costs. And then for non-personnel services, we do see 4.4 million of overspending related to the city option cash grant program. And again, as commissioners may recall, this was a program that was set up by the mayor's office to allow $500 cash disbursements for participants within the city option. It was a wildly popular program. We had assumed, I believe, 11.5 million of spending, but it was actually about 4.4 million over that instead. And then within population health, their patient revenues are continued to have a one-time delay as they were delayed in getting online with Epic, which was delayed as part of a response to COVID, as well as a reduced collection of environmental health services as directed by the mayor's office to delay the collection within environmental health. And then again, significant level of salary and benefits costs being redirected towards COVID and some minor shortfalls in materials and supplies. The other thing I will note is on our management reserve, as commissioners may recall, under the administrative provisions of the annual appropriation ordinance, we do have a management reserve. The current balance that we have is 59.5 million for these three items here, 15 million for potential negative revenue impacts due to the transition of our Epic billing system, 5.4 due to changes in patient rates that started in 1920, and then 39.5 due to formula change related to our enhanced payment program. It's possible that this may be delayed or mitigated by future adjustments from the state. One of the things that I've been working on is I've been working with the controller's office and the mayor's office to review and update the methodology for calculating the reserve. And I will be coming back to the commission likely within the fourth quarter to update the commission on any potential recommended changes to this program. Shifting over to the citywide COVID response project. And again, this is the new budget that was created by the mayor and board of supervisors last year. These are the new costs related to COVID. Overall, at the 9-month, the controller expected that there's about 106 million of fund balance available due to increased spending. increased support from state and federal grants, as well as reduced spending within the project. They assume that 53 of it would be available for reserve for claiming and disallowances related to FEMA, and then an additional 53 would be able to offset continuing COVID response. These variances aren't reflected in our report. And again, like our COVID project, expenditures and revenues may fluctuate due to cost reporting and reimbursement requirements, particularly at year end, as we work with our auditors. And then I noted the surpluses and how they'd be used here. Specifically within the DPH cost centers, vaccinations, we are projecting 26.8 million of spending by year end. The new cost is almost entirely offset by FEMA at this point. Testing, what we just saw in the second quarter is with the real uptick in vaccinations, what we saw was a corresponding decrease in the demand for testing. And so from our second quarter projection, we saw 76 million. We're expecting, if we continued at the pace we were at, of 76 million of expenditures, but at this point, at the 9-month, we're projecting 57.8 million instead. PPE has also been updated to reduce projections to 37.5 million compared to the 47 million that we were projecting to better reflect the expected use of PPE. And then we also have just sort of general savings due to the retention of the disaster service workers from within both DPH as well as other city departments, which enable us to delay hirings, as well as a reduced impact of a surge. The winter surge we were able to curb, and then we thankfully did not see another surge in this spring. So these savings are sort of sprinkled across multiple divisions within the COVID project. So that was my presentation. I am happy to answer any questions the commission may have.
Commissioners, may I please check the line and make sure we don't have any public comment first before you go on to your questions. Folks on the line, if you'd like to raise your hand to press to comment, please press *3. We're on item 9. No hands, commissioners.
I had a question back to the Zuckerberg shortfall of 21.36 million related to the shift in payments for the Quality Incentive Program in Prime. So just so that I understand more, so So does that mean that we should see that revenue come back in for fiscal 22? Or is that, we can't accrue that in this year knowing that that's going to come in? Or do we have to wait until the cash actually is?
Sure. I mean, at this point, we don't, because we don't expect the payment. There's, it's a little bit complicated, but and I always get the two confused. But I believe that the quality incentive program ran on a fiscal year and Prime ran on a calendar year. And so what they did was they aligned it so that it all ran on the same time period, which delayed the QIP program by 6 months. And so I think the payment, everything is just delayed by 6 months. So there's no catch-up payment we would expect to see in 21, 22, as I understand it. But the payment sort of moved to the end of the program.
And so when would we see that showing back in the report, or do we?
I mean, we probably would see it at the tail end, and I will confirm this, but I do not expect that we would see a one-time bump up of 20 million in the financials for 21, 22.
Okay.
But it's a 6 month delay.
But it'd stay within the reporting period, you think? The current reporting period? It just can't be reported now?
It can't be reported now, but I believe that we will not see the shortfall moving forward.
Okay, thank you.
So I wonder, as we're looking at the surplus, and we heard at our last commission meeting, the shortfall in the renovations due to the increase of materials and personnel and shortages and delays. Can any of these surpluses be used to help to bridge that gap?
Sorry, the renovations of.
Well, the renovations that we have at General, not talking about, well, it also includes the clinics, but most of it's at General and in Building 5. And we were given the information, of course, that materials had all gone up in price. The bidding for services were all up in price. There were a number of patches that they were hoping to be able to bridge the a shortfall in order to be able to continue the work. Well, not just to continue, but to complete the work. And as we're looking at some general fund surpluses, wonder if any of that actually could be used to assist in the renovations.
And Ms. Louie, this is for the public health and safety bond project.
Correct. Yeah, and so that is not a general fund source. Basically, how it does work is that there's expenditure authority as well as surplus revenues that we have, and what we're really seeing drive the projected 74.4 million of surplus is the 22.5 of revenue surplus, as well as the 51 million one-time release of reserves. And so that is additional revenue, but it does not represent actual expenditure authority. So neither I or anyone else has the ability to expend these dollars because they haven't been appropriated. All we have in terms of excess expenditure authority projected is 0.2 million on the expenditure side. And then also, as noted earlier, these surpluses have already been recognized by the Mayor and Controller's Office in their 9-month report, and they were used to balance and help pay for the expenditures in the upcoming 21-22 budget. So at this point, these balances are not available to be reapplied anywhere else. Like the savings has already been applied and are used to appropriate costs for next year. And so, but we will continue to work with Mr. Saltz and then work with the Mayor and Controller's Office as well as the Capital Planning Committee to reevaluate some of our costs and needs and determine ways that we may be able to support it in the upcoming fiscal year.
Thank you.
Any other
Any
questions?
other questions?
Shall we go on to the next item, Commissioner? Okay. Thank you, Ms. Louie.
Thank you, Commissioners.
Item 10, Commissioners, is emerging issues. I am noting for the future emerging issues, the topics that you discussed today around too big to fail agencies as well as outcome data. Let's see, item 11 is public comment. Folks on the line, if you'd like to make general public comment, which would be on something, a topic that's not listed on the agenda, please press *3 to raise your hand. Again, *3 for general public comment. No hands, Commissioners, so now there is a consideration for adjournment.
So
Move adjournment. Second.
All right. Commissioner Guillermo,
Yes.
Commissioner Chow,
yes.
and Commissioner.
Yes.
All right. Thank you for the lovely meeting.
Well, thank you and see you at 4. Yes.
Bye-bye.
Bye.